Okay, lessons with Mick. This one's going to be a quick one. Today we're going to talk about ketamine. A very interesting drug. I'm not really going to get into dosages and things like that, but why ketamine? So ketamine, for one, is relatively, I guess, not very well understood by medical scientists. It's direct action, the very complex pathways that are involved, all the cascading neurotransmitters. Not really that well understood. And if you remember from my previous talks, the RAS system, for example, pretty well understood how I drew that out. The adrenergic versus the cholinergic nervous system, pretty well understood. But sometimes in science, especially medical science, especially when things are new, you can't explain it that well. So the best that we can do is remember the signs, symptoms, and be cognizant of some things that are evolving over time. Drugs like this are why evidence-based medicine is so important. It's things like this that we should be paying attention to closely as clinicians, in order to be ready for any sort of changes that come about in the literature, and I'm going to explain a couple of those today. So first of all, ketamine, right? Just a few common uses. Recreational. I think it's been used since like the 1970s for feel-good type highs. 2, pain. I guess more recently, pain management. But before that, it's been heavily used as a induction agent for intubation. So induction and sedation. And then, see how I'm getting more recent with these? Well, I guess recreational is pretty old, but as far as how it interacts in the body, what's newest in medical science currently is depression, anxiety, and those kind of other, I guess we'll call it just a blanket term, it's psych conditions, because I'm not going to go into them today. So let's talk about the pathways. Like I try to do, I'm going to talk about the pathways so you have a fair understanding of kind of A to B to C, and then a bunch of crap's going to happen in the middle. We're general practitioners, I've said this before, so we're not really going to care about it, but it's good to know kind of what's happening so that you're not surprised when there's interactions, or like, you can kind of, what's that show with the genius autistic, The Good Doctor? Yeah, do one of those where you're like, wait, I remember this one time this person said this about this, and maybe that's why this is happening, and then who knows, maybe you'll be right. So we'll just go into very generic breakdowns here. Ketamine, chablamp. Norketamine. And this is really no different than like what drug tests test for, right? They're not testing for the actual drug ketamine, they're testing for the metabolites. Last longer in the body. So these metabolites are important because the activation of them and then what cascades from them is actually what causes the end organ tissue, or the ultimate tissue activation, the target organ activation here. So keep going. Glutamate. I'm not going to get into glutamate, but just like cyclic AMP, glutamate, and all these other signaling molecules, research glutamate on your own if you would like to. So the important thing here is NMDA receptors. Everybody's heard of serotonin, dopamine. Well, you got another one. NMDA receptors. I talked about some other receptors last time on the cholinergic side of the house. I talked about nicotinic and muscarinic. Well, guess what? NMDA. Do some research on it if you would like. I'm sure there's plenty of quick 5-minute videos you can watch that will explain why this is the way it is. But the important thing to take away from the NMDA receptors is that they are excitatory. And if you go back to what I just talked about, what's all this? It's not excitatory, right? People get high and in a trance. People have less pain that they're aware of, I guess. People are inducted and sedated. And then depression, like this is not excitatory stuff, right? So what do we think ketamine is? It probably blocks neurotransmission. Because ketamine is blocking an excitatory pathway, thereby, sedating a patient. So not really going to talk about all the neurotransmission that's involved in this. Like I said, it's pretty complex and a lot of the pathways aren't really well understood in medical science. So we're going to chalk it up to it's an evolving field and take it upon yourself to do some more research. And because we're in the habit of evidence-based medicine, it is on you to at least acknowledge that this is a rapidly changing field of research here. So this is not fentanyl, right? So be extra cautious with drugs like this. Not saying be scared of it, but just know that it's relatively new. And then I'll give you a little bit of a horror story. I had this patient once where I gave them ketamine for sedation. They were really hard to keep sedated. They were significantly ill. Maintenance of their airway was required. Continuous maintenance of their airway was, protection of their airway was necessary. So benefits versus risks. Obviously needed to keep them down, chasing our tails the entire time. Opted to switch to ketamine. Significant. Now we gave it over the 2 minutes like you're supposed to, but significant hemodynamic collapse following that. Now, this is a little bit of a conundrum because could the hemodynamic collapse have been caused by something that was, the process that was making them ill? Yeah, absolutely, right? It's hard to say for sure that it was from the ketamine, but I can say that I had this patient for an hour to an hour and a half, and then the blood pressure was relatively good, and then it wasn't a minute after I gave the ketamine, and I'm talking like high pressure alarms on the ventilator, no recognizable end tidal, skin modeling, no detectable blood pressure, calcium, push dose epi, the whole 9 yards. I couldn't even really detect a heartbeat, so kind of peri-arrest, if not treated it as if it was kind of an arrest. Everything worked out for the patient, but yeah, very scary. So I did some research as to why, right? So that's what this talk is kind of about, right? So what is known is that ketamine has a very direct involvement in the adrenergic nervous system. And if I get some of this wrong or I'm not 100% correct, I apologize, but this is kind of what makes sense to me. So alpha 1 and beta 2, right? And we've talked about what these kind of do. I said in the last video, 1 heart, 2 lungs. This is a sympathetic, so fight or flight, FF response. So everything's constricting, except for the pupils are dilating, right? You get and your bronchioles are opening up more, but your smooth muscle and all that stuff is more blood for you to fight the bear and run away and all this stuff. So more blood pumping, higher blood pressure, higher heart rate. This is all opposing the parasympathetic nervous system, which is in contrast to what I talked about last week, which was the cholinergic nervous system. This is the adrenergic sympathetic activation. So what I do know is that ketamine has stimulatory effect on these, right? So most of your patients, or if you read about ketamine, you'll see a transient increase in blood pressure or a transient increase in heart rate, sometimes 15-20 beats a minute, and sometimes 15 to 20 millimeters of mercury or more increase in your systolic and diastolic blood pressure. And one of those sort of old, I don't want to call it bro science, but I'm going to call it bro science. People are like, if you have your significantly ill patient, super hypotensive, hypovolemic, blah, 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 just use ketamine, it'll increase their blood pressure. I think the research for that is done more towards surgical candidates, people that are in optimal settings that don't have, such a high acuity of a life-threatening thing going on. nobody does an elective surgery when they're circling the drain because they might not make it through the surgery, and I have a feeling that most physicians and anesthesia teams don't want to get sued. So why does it increase blood pressure and heart rate in some, and why does it lead to potentially disastrous crashing patients like the instance that I had? Well, it kind of comes down to your shock index, right? So let's just be very basic about this, because I think that's what it is. I think when somebody's significantly ill, doing this, circling the drain, all the while their body is trying to compensate. So what does it do? RAS, renin-angiotensin, aldosterone, alpha-1, beta-2, get blood to the organs, prevent tissue hypoxia, keep homeostasis, keep the, avoid anaerobic metabolism, and keep the pH where it needs to be, right? So you're kind of depleting all these, just like you do clotting factors, and when you get into why disseminated intravascular coagulation is the way that it is. I think that is a comparison here, right? So you're using all these alpha-1, all these alpha and beta adrenergic receptors, just like you're using up all your clotting factors and DIC. And then eventually, why do you get into DIC? Nothing clots anymore because you're out of clotting factors. Well, why do you crash? Maybe you're out of alpha-1 and beta adrenergic alpha and beta receptors. So then what do you have? You have nothing to now oppose your parasympathetic nervous system. And like I talked about pretty extensively in my last video, it's 49 minutes. Parasympathetic. You got nothing. you got no gas now. All you have is brake. So you're gonna slow down, right? So you've got nothing to oppose your parasympathetic nervous system. And as I explained in my last video, decreased heart rate. You have vasodilation from nitric oxide, which is by muscarinic 3, something like that. Probably a couple others as well, but you get a decrease in vascular tone. You get a constriction of. Maybe that's why I had high pressure alarms. Maybe I had massive constriction of the cholinergic, maybe the cholinergic nervous system here caused massive constriction of the airways, because when you're resting in digesting, you don't need to move a lot of air. So maybe I had unopposed bronchial constriction, decreased vascular tone that led to end organ perfusion issues and skin modeling, ultimately decrease in heart rate. I don't remember what that patient's heart rate was, but you get the idea, right? Yeah, it might have even been PEA, who knows. So I'm thinking you're just using all of these alpha and beta receptors to such an extent, and then these patients that are horribly adrenergic depleted, you're then saying, give me more, by giving them these high doses, 150 milligrams of ketamine, right? And then any last bit of the adrenergic receptors that you had left, now you got none. Just like your clotting factors, you go into DIC, and in this time you go into hemodynamic or cardiovascular collapse. So I think that's what's happening here. I really do. And for all these really complicated pathways, and then all of them that are unknown. So how do you know when somebody's depleted all of their clotting factors? I'm sorry, not clotting factors, but adrenergic, right? So we're going to use something called a shock index. And unless somebody gets shot in the ventricle, we're talking about disease processes or illnesses or injuries that are progressing, right? And then if you don't give care to the patient urgently, then 10, 15, 20, 30 minutes, an hour, 2 hours go by, and then they circle the drain, right? We're talking about these patients. We're not talking about the types of patients that that have a catastrophic, non-life-saving, like an aortic tear from being an understrained driver and hitting the steering wheel. That's not these patients. These patients die from catastrophic exsanguination way prior to their adrenergic receptors being depleted. I'm talking about somebody with a GI bleed that's 6-12 hours in, right? So these people that have a slowly decreasing blood pressure and an ever increasing heart rate, well, there's this ratio that the two of these meet together, and it's called the shock index. I'm going to write it over here so I don't have to use another page. Save the turtles. Shock index. And it's a very easy equation. You you're looking for anything. I think I've seen 0.8 in some resources, and then also 0.9. But remembering about 1 is always a good, starting point. So anything less than these, that's good. Anything higher than these is no bueno. Put a check mark here, right? So what would give you a shock index of, let's say, 1.2? Well, we know the heart rate's going up, and we know that the blood pressure is going down. So just mathematically, one over the other, what would you think is going to be on top, and what do you think is going to be on bottom? Well, I'll tell you, if this number is low and this number is high, let's say 50 and 100, that's a half. So it's not it's not the blood pressure on top, and it's not the heart rate on bottom. It's the other way. It's the heart rate on top divided by the blood pressure, because that would give you, let's say your heart rate's 60, and then your blood pressure is 120. We're talking about systolic blood pressure here. That's a shock index of 0.5. Those patients, A-okay. However, let's say your systolic blood pressure is 60 and your heart rate is 120. Let's flop these. Now you got 124 heart rate. That's a really bad blood pressure, but that shock index is 2. Well, that's greater than 0.8 to 0.9, right? So these patients that you have a very high shock index, you are worried that they don't have any adrenergic opposition if they were to be depleted. So if you give a drug that acts heavily on alpha and beta or adrenergic stimulation, and they have a really high shock index, there's a very high, and you can read some reports about this, there's a very high occurrence of hypotension and bradycardia associated with these patients. And if they're already kind of at that teeter-totter, well, my hand was closer than I thought, teeter-totter zone, then you really never know. Like sometimes just a stiff wind will cause these patients to crump in front of you, right? So you don't want to push them. You don't want to be the final straw that broke the camel's back. So let's summarize here. Ketamine, confusing drug. It's new, so you owe it to your patients to keep in the back of your mind, or keep in the front of your mind, that research is evolving for this, right? So there's bound to be evidence-based medicine coming out for this type of stuff more frequently than other type of stuff. So if you want to be up-to-date current clinician, you should do some research on ketamine and things that are sort of evolving like ketamine. What are its uses? Recreational, pain management, induction and sedation, RSI process, right? 1 to 2 milligrams a kilogram. And then I said I wasn't going to get into doses. And then depression and psych conditions. That's kind of a very new science. It's being trialed. Some people probably don't even do it. That's how new it is. So we're gonna steer clear of this sort of like limbic system pathway. So let's talk about the stuff in the middle that we're gonna forget: ketamine, norketamine, glutamate. Research that if you want to. NMDA receptors. When they're stimulated, it's excitatory. But we said that since ketamine calms everything down, we're obviously blocking the excitatory pathway. So we are decreasing neurotransmission, and whether that's neurotransmission on the NMDA pathway or a bunch of complex cascading events in between, we don't really know. But we do know that it is decreasing the excitatory pathway, right? And there has been direct linked evidence that there is direct, right? Like 1-to-1, not even like an indirect pathway, but direct involvement of alpha-1 and beta-2 or adrenergic receptors when this drug's given, right? So if you're giving this to somebody who's been slowly depleting them, who has been kind of circling the drain for a while, you never really know when they're going to get to that point where they only have just a little bit left in the gas tank, and you go ahead and you give something that depletes the rest of those, and then they go to zero, and then you have hemodynamic collapse. And what is the way that we're going to measure this? We are going to use the shock index. Is their heart rate so high and their blood pressure so low that the shock index increases above 0.8 to 0.9? The higher the number, the higher the shock index, the more likelihood you are percentage-wise of look this up, look up surgical patients in ICU, or not ICU, surgical patients that are have a high or low shock index that are induced with ketamine, and then watch the overall really high confidence intervals here, right? 95% confidence intervals in some of these studies. Look at the amount of patients that have a decrease in heart rate and blood pressure as opposed to the normal response. which is a transient increase in heart rate and blood pressure. So you know that if you have somebody who has just been circling the drain, and you're like, well, I picked this patient up from home 3 hours ago. They're now intubated, and now I'm transporting them to a tertiary center to get a higher level of care, and it's been 4 hours. And if that patient has a shock index that's 1.4, 1.6, 2, probably not the patient you want to give ketamine to, right? Probably the patient you should be giving blood to and maybe some low-dose pressors. And if you can't get the results you want on the Versed and fentanyl and the propofol that you're giving the patient, it's possible that their hemodynamics are so bad that the drug just isn't metabolizing. But if that's the case, then they don't require as much medicine anyways, right? Because if their whole body is kind of not metabolizing the way it should be, you don't need to get the propofol down into their finger. You just need to reach the central nervous system. And when somebody has a really low cardiac output, that's easier to do. So some of these patients, just for your sort of working knowledge here, you don't have to give 100 micrograms of fentanyl to. Sometimes you can give 50 to 75 micrograms of fentanyl and you get the same effect. So patients that are really, really circling the drain, give them whatever they're lacking. If it's fluid for sepsis, if it's heart failure and that's why they're hypotensive, you got to give them some sort of inotropic pressor, right? Vasopressin, dobutamine, things like that. And then, I would say these patients with a really, really high shock index, if you're not getting the results that you want with your current sedation, change something, right? If you try to intubate somebody with a MAC3 and you just keep failing, well, maybe it's time to use a Miller, or maybe it's time to let somebody else try. Same thing goes here. You keep giving the same dosages of the same medications over and over, hoping for a different result, and then you're probably not going to find one. So maybe suction the patient, do other things that'll make them comfortable, change the position, drive a little slower, maybe make them not bounce up and down as much, because if you go 80 to the hospital but they're going the whole time, it might be worth the extra 5 minutes to not do that to them. Maybe use nicer vent settings, or change your mode, or reparalyze them. So start thinking other ways, because I have personally seen these patients crump in front of me. Now I can't attribute it directly because it was no science is done based off one thing, but I'm skeptical going forward, giving these crashing patients that have been circling the drain for a while such large amounts of ketamine, knowing that the way that this pathway works on the adrenergic nervous system, if I totally deplete all of these and they have unopposed parasympathetic activity, they're 80/40 blood pressure that I work so hard to get, just to keep them in a map of 55 to 60, might go down to 60 over non-detectable, and that might cause modeling and peri-arrest and all sorts of alarms and dings and poor pleths and non-recognizable SpO2s and things like that. So that was good. That was less than 25 minutes today. All right.